Welcome everyone. This is a panel on health. We will address. I don't know what's going on. So I was saying that this is a panel on. When I start, it stops. Okay, I repeat it. It's a panel on health, the health of refugees and migrants. And as you know, I mean, when we... So what I was saying is that when we talk about the health of when we talk about refugees and migrants, I mean, we do tackle and address the issue of health, of their health, mental and physical health, in many aspects. When we talk about welcoming policies, when we talk about their education, when we talk about their integration in general, the determinants of health are really everywhere, even if we don't actually really take that into account or recognize that. And it's one of the most important issue at the global level when we talk about refugees and migrants. And I do say this because I actually dealt with this at the UN level for many years now, and the last 12 years. And recently I worked, as I was mentioning yesterday, for the Italian Prime Minister office under the presidency of the G7, which is this international fora that takes place every year in different countries of the seven so-called biggest economies, even if it is not true. I actually apologize with the speakers. I was giving this introduction because I wanted to actually open this session before I introduce all of you and your intervention with a small news. Yesterday it took place the G7, the Health G7, which is the meeting of the health ministries, of the health ministers of the G7 countries plus the European Union. And they came out with the final declaration that it's a very interesting one. And I wanted to actually introduce the issue just going through the final declaration, because I believe that it could be interesting to look at how the seven countries, so US, UK, Germany, France, Italy, Japan, and Canada, plus the European Union, addressed the issue of health of refugee and migrants for the first time, actually, in the history of the G7. And for what it's worth, actually, the G7, it's an important document. All the documents that are coming out of the G7 could be important if there is afterwards people, entities, NGOs, governments that take that document and try to keep accountable those who undersign these documents. So I think that it is an interesting document that for first time talks about the importance of the health, psychological, mental, physical health of refugees and migrants. So I'll go through the two paragraphs very fast, and then I'll introduce the session, and so that we can go ahead. Can you read? I don't think you can read, huh? Yeah? So, is this working? Does it work? Yeah. Paragraph 25 and you see 25 and 26. And we welcome and support the provision of health services, particularly including immunization programs for migrants and refugees. And this is addressing the mixed flows of migration. So not just refugees or asylum seekers, but all type of migrants. And this document is addressing also the environmental migrants. We were talking about that yesterday. Including in situation of forced displacement and protected crisis, as well as the improvement of health services in transit and destination countries. This includes making immunization programs and clinical services available and accessible to everyone, while increasing the surveillance and infectious disease and the monitoring of NCDs and their risk factors. And probably today we will talk also about NCDs. We will seek to improve access to physical and mental health services and assistance to migrants, refugees, and crisis-affected population as appropriate. We will promote the identification, sharing, and adoption of good practices, and this, I think, is very important for university and academics, to address psychological needs of refugees and migrants. Following the adoption of the New York Declaration for Refugees and Migrants in September 2016 and the resolution of the World Health Assembly in May 2017, the support for migrants and refugees should consider their specific needs, leaving no one behind and in line with the Agenda 2030 for Sustainable Development. I think is a very important declaration that, as I was saying, addressed for the first time the needs, the health needs of refugee and migrants in this fora. So I wanted to start with this because this happened just yesterday afternoon, and I was actually following it from there. Yeah, and it took a lot of effort from many activists, NGOs, and also the civil society and academics in these 7 countries and in some European Union countries to achieve this negotiation. And it was very, very difficult, especially because of the position of the US administration. But I think that it is an important start. Let's go to the panel, and today we will have presentation from, I apologize in advance for my pronunciation, but we Italians have difficulties with this and the language accents. Your name is the easiest. So Dr. Fouad, Director of Refugees Health Program, Global Health Institute of the American University of Lebanon will go first. We'll give a broader introduction. Then we will have Dr. Khoshnood with a special focus on infection disease. He is the director of undergraduate studies at the School of Public Health of the Yale University. And then we have Dr. Jomaa, a nutritionist and food scientist, and she is also the co-director of the Refugee Health Program at the Global Health Institute here at the American University of Beirut. And then our policymaker and expert, Dr. Saleh, who from the Department of Health Management and Policy, and he is also the Vice President for the Health Affairs at the American University of Beirut, and the founding director of the Global Health Institute here at the American University of Lebanon. So, Dr. Fouad, I would start with you and your floor. Actually, we do have not more than 7-8 minutes because we're a bit late, and we would like to open it to the question and answer. Please.
So, good morning. I have only 7 minutes, so I'll try to use it as good as I can. So I will start with sharing a story with you that happened 4 days ago when I have a class with the medical students on their residency, actually their second year of residency. I mean, it was about refugees' health. And I asked them the first question, when I said refugees' health, what's the first issue that come to your mind? And one student said lice. The second one said tuberculosis. The third one actually said leishmaniasis, which is, this skin lesion. And no one mentioned to heart diseases. No one mentioned to asthma. No one mentioned actually to any of chronic diseases. So refugees' health, after 6 years, 7 years here in Lebanon, the first thing comes to mind is infectious diseases and what they called it, dirty diseases. So the issue is about when you have refugees, that's what we think about. And that's my presentation will be about the issue of changing health needs in protracted crises. As you all now see these numbers, we're talking about 1 billion people, or 14% of the population now live in conflict areas. 74% of direct conflict-related death actually happen in 3 regions, in Africa, Middle East, and South Asia. And 23 actually, out of 32 protracted refugee situation, last now more than 20 years. This is an evidence about protracted crises. Mostly are in urban settlements. That makes now, as mentioned here, world is now seeing more refugees and IDPs than ever before. So this number, that's our famous number since the last 2 days, but mention here that out of those 21 million that are refugees and not internally displaced, out of those, 10 million, almost half of them, are from Syria and Palestine. So we have only from 2 small countries the most, refugees. That means only in this region, half of the refugees worldwide are in only 2 regions in this country. So let me just give some ideas about what's the current, humanitarian aid system framework. Actually, it's built on the experience of these 2 issues. First, it's about the refugees are living in camps. Second, refugees are coming from low-income countries. Third is by ignoring, political determinants focusing more on humanitarian / social issue. And then the response to that is just due straightforward. And as we saw in the declaration, they mentioned to immunization as a first issue, which is good that we have now NCDs in the second line. So, responding by, immunization, antibiotics, some sort of supplement for nutrition, and so on. So these issues of the humanitarian aid, the current humanitarian aid system actually has been shaped around these issues. Whereas actually what we have now, and Syria is a very clear example, we have now a crisis in middle-income countries, Iraq, Syria, now Libya, before that Kosovo. So what does it mean to have people or crisis from the middle-income countries? First, that means the expectations are different. They have already, relatively good indicators in health, in immunization rate, in a sort of infectious disease. For example, in Syria in 2010, 77% of death causes are because of chronic diseases. 48% of adult people have hypertension. 42% of women, adult women actually, are obese, We're talking about different, profile of diseases that's almost developed country diseases. So people when they move with different expectations that only clean water and vaccination. Second issue is that now it's, as I mentioned, it's an urban settlement, it's urbanization of refugees. You know now the 3 major, the 3 countries that hosting the majority of refugees in Turkey, Lebanon, and Jordan, 85% actually of refugees are living in non-camps. In Lebanon, it's 100% are in non-camps. So camps is not now the main type of hosting refugees. What does it mean? This is an important question about integrating people in the system, which is a very sensitive word when talking about integration? Are we talking now about universal health coverage? There's a must to do that. Talking about what about the legality, of those people, how they can move and how they can be legal in their setting. The other issue is that there's like a sort of massive movement of population in short time. So again, for Syria example, we have like a sort of almost 12 million that move in 6 years, whether internally or externally. One of the characteristics also of these new crises is also it's a sort of unsolved conflict. Just think about Afghanistan. It's now almost 33 years. Iraq, now Syria, Libya, so in Congo. So it's a different part of the world. We have a sort of not just long-term, but also unsolved, problems. The other characteristic is militarization and politicization of the healthcare itself. And we have many examples from Syria about attacking health systems, and that's in Afghanistan, now in Yemen, so in different parts of the world. So these 4 key questions that we need actually to raise, because it actually received very little attention on that. First is how to structure aid program in the poor governance states. So, taking in consideration the issue of corruption, the issue of repressive. Second is about how we reconstruct humanitarian aid, in a sort of long term, not just emergency. And I think that now the word emergency in these issues of crises is quite far away from the reality. And I can give you an example from the Palestinian crisis. When we have now refugees since 68 years, that means this is a different from 69 years now, from the issue of emergency. We can describe it as a chronic emergency. So, and then how to meet short-term needs while developing is an important issue in this matter. Then the issue of decentralization strategy that's needed now to think about it when thinking about providing services. So when thinking about reforming a broken international humanitarian aid system, as Paul Spiegel mentioned in the Lancet, actually we need to think about these also different issues. The humanitarian development gap that needs now to consider that, it's not just a humanitarian, it should be a sort of development. The issue of collaboration between different sectors. Can we think about a role of private sector in this issue of humanitarian development part? Thinking about that all person in one area should have an access to health. And when talking about inclusiveness, that means we should have a sort of avoiding parallel systems. And I'll give you an example here in Lebanon. There's a system for the government system. There is a system for, talking about health system for Palestinian by UNRWA. Now third system is the UNHCR for Syrians and the different NGOs working in this system. We need to be sure that all people in a specific area, whether it's small area or countrywide, have like equitable access and similar level of quality for all population. And that's very important when thinking about, a sort of having a level of health services and actually health outcomes. I will stop here and we'll leave that to the discussion. I hope I'm on time.
Thank you so much, Dr. Fouad. And so I leave the word to Dr. Khoshnood, and I don't know if you want to go to the, yeah, that's nice.
Good morning. I want to start by thanking the organizers, especially Eric and Nasser and their staff for inviting me. Last night, I don't know if you had a chance to listen to Dr. Dean Iman Nawahid, the Dean of Faculty of Health Sciences. I was very inspired by his speech last night. And he told the story of how he raised this question to the Faculty of Health Sciences of what's the role of a School of Public Health or Faculty of Health Sciences in the context of a refugee crisis. And in fact, the question that he posed to his faculty is exactly the question I had been asking myself for several years. As an infectious disease epidemiologist who has been working on HIV/AIDS epidemiology and prevention for 2 decades, and is from this area. I was born in Iran, and you know, I was asking, what's my role as an infectious disease person in responding to this? And I had the good fortune of having a sabbatical in 2013-14, and I decided to come and spend some time at UB and got to know some of the faculty, Fouad included. And basically, what I was asking is, what could somebody with my skill set as an infectious disease epi person sort of bring to this issue? To what extent HIV/AIDS is a problem? To what extent substance use is a problem among the displaced population? And what became pretty clear is that we don't know. There's not really much data available about the HIV/AIDS problem, about the substance use problem. So I sort of began to work on this area. Out of my sabbatical came 2 sort of concrete projects. One is a course that I developed on violent conflict and health, epidemiological methods and public health interventions. Happy to share the syllabus to anybody who's interested. And then the second kind of a concrete project was, there was a call for proposal from the National AIDS Program in Lebanon and MENARA, Middle East North African Harm Reduction Association. And what they were looking for was what's known as a population size estimation. So the question was, what is the population at risk for HIV in Lebanon? And they had a particular interest in 2 groups, men who have sex with men and people using drugs, injection drug users. So we put together a proposal, was successful, and we ended up doing this project in 2014-15, which I'm going to tell you about in a minute. And basically in the course of about 4 months, using what's known as respondent-driven sampling, a form of chain referral sampling, we were able to recruit about 300 men who have sex with men and about 400 people who inject drugs, and interviewed them about their risk behavior, asked about HIV testing, offered HIV testing using the NGOs that are quite active in Lebanon. Some of the findings, by the way, one of the questions we asked in the beginning was to what extent there was an interest to look at the displaced population, and the answer was don't go purposefully sampling from displaced population, but if they end up in your sample, it's okay. So at the end of the day, of the about 300 men who have sex with men, about 75% were Lebanese born and 25% were Syrian born. I will return to this. Of the about 300 MSM, 36 individuals tested positive for HIV. 32 of them already knew they had HIV infection. There were only 4 who realized they're HIV infected as a result of our study. The estimated prevalence of HIV among this population was about 13%, which is actually quite high. Those who were HIV tested were older, were born in Lebanon, and had higher income. The good news is almost all of them were currently receiving antiretroviral treatment. Now, in comparison, only 5% of the Syrian MSM, men who have sex with men, were HIV infected, compared to the 13%. However, when we ask questions about access to testing, about experience of stigma, discrimination, prejudice, physical and sexual abuse, and exchanging sex for money or drugs, the Syrian MSM had far higher rates reporting of stigma, not having access, and so on. So given the fact that there seems to be quite a bit of mixing between the Syrian born MSM and the Lebanese, there's a significant risk that the Syrian MSM would be getting infected at a high rate. From that study, we ended up proposing two different studies that we are hoping to launch this year. One of them is a 2-year NIH-funded study. The idea here is to recruit the largest sample of MSM population in Lebanon, about 1,000 men who have sex with men, using the same respondent-driven sampling with a ratio of 3 Syrian-born MSM to 2 Lebanese-born MSM. The primary goal of the project is to look at HIV testing rates, prevalence, and incidence of HIV, comparing the Syrian-born and the Lebanese-born, and to develop an intervention based on the results that we will gather. We are hoping this study will significantly improve our understanding of the effects of forced displacement on HIV risk, something which really hasn't been studied in this region much. The second study is focused on substance use. It's a pilot study. The idea is to do a rapid assessment and response to substance use and risk of HIV and other bloodborne infections, hepatitis B, hepatitis C, among both the Lebanese nationals and the population. This is a qualitative study. What we are planning to do is to interview 80 individuals, half Lebanese, half displaced population, Syrians, Palestinians, Iraqis, and ask about the problem of substance use, to what extent this is a problem, how is it affecting their lives, their families, what access do they have to harm reduction services, et cetera. We are also planning to do key informant interviews with stakeholders, about 10 or 15. So those are the two projects that have both been funded and we are hoping to launch this year. Now I want to return so that the question that was raised a lot yesterday, and sort of a theme of this conference, which is what's the role of academia in producing the evidence to inform kind of right policy or progressive policy? And a question that I've been asking myself all along is, will the data that we are collecting, in this case on HIV/AIDS, among the Lebanese but also among the Syrian MSM and drug users, will this data bring attention and attract resources to these public health problems without inadvertently adding a new layer of stigma to a population that's already burdened by stigma? And of course, I'm talking specifically about refugees and other displaced population. My own experience from sort of HIV/AIDS work, especially when it comes to syringe exchange programs, needle exchange programs, where drug users are offered clean, sterile syringes in exchange for used one, is quite mixed. The data that we helped gather on the efficacy of needle exchange programs did move policy, I would say, in the right direction at the local level. So in the city of New Haven, Connecticut, where I live, our local officials, once they saw the evidence of the efficacy of syringe exchange program, that the program actually reduced HIV rates by 33%, they were quite impressed by those results and launched, the New Haven Health Department launched one of the first needle exchange programs in the country. New York City followed the same pattern and started its own needle exchange program. So we did see kind of the right policy to reduce HIV among drug-using population. But at the federal level, the data that we had helped produce and some other data from our other colleagues was ignored, misused, manipulated to justify what I would consider ideologically driven policies. Obama administration lifted the federal ban on using funds from the federal government for supporting needle exchange program, but without allocating any funds. And then when the Republicans took over the Congress, they actually reinstated the federal ban. So my experience from producing evidence on the efficacy of needle exchange program is really quite mixed. There's been some very positive outcomes, and there have been sort of negative outcomes. I have similar concern about the work that we are embarking upon in Lebanon. And I'm happy to share with you some of our thoughts and strategies of how do we reduce the likelihood that the data, that evidence that we are helping to produce will result in bad policies. But I would also very much appreciate sort of your thoughts and experience and suggestions. So let me stop there and maybe have questions about this. Thank you.
Thanks so much, Kaveh. We will open to comments, consideration on all this intervention. I give the floor to Dr. Jomaa, and yeah.
Good morning. Okay, while Microsoft is figuring out stuff, I'm going to start. Lamis Jomaa, I come from the Department of Nutrition and Food Sciences and also the co-director of the Refugee Health Program with Dr. Fouad and also with Dr. Saleh. So today our talk is going to be more about the food and nutrition security status of refugees and the host communities. As previous colleagues have been talking, a couple of the slides at the beginning are going to be fast, given that we've actually shed light on this in the past 2 days. You can see it there, but I can't see it here actually, so how can I move forward? It's okay. All right. So it wasn't opening properly. Okay. Thanks. Can't take that minute away from you, can you? So these are figures that you probably heard so much are grappling with throughout your work. As we know, more than 65 million individuals are forcibly displaced, 22.5 million of which are refugees. Refugees are coming from the top 3 countries, Syria being one of them, of course, Afghanistan and South Sudan. Top hosting countries, they include Lebanon, they include Turkey, and other countries in the MENA region, as well as abroad. What's going on with Lebanon? As we know, we are actually in the top chart in terms of the number of refugees per host population. We consider that we have 1 in 4, so 1 refugee per 4 individuals in Lebanon who is a refugee. According to UNHCR data, as of June 2017, we have more than 1 million Syrian refugees. These are registered refugees. This excludes the number of unrecorded, unregistered Syrian refugees, as well as Palestinian and Iraqi refugees that have been in Lebanon for decades, as Fouad was saying and as my colleagues were talking about. So we know that there's so many challenges that the refugees are facing, and this is by no means a comprehensive list. This is just kind of shedding light on and summarizing some of the stuff that we are handling here. One of this definitely the limited assets and resources that refugees are having, especially that we're entering the 8th year into the crisis. You can imagine that the coping strategies that have been actually adopted, the assets that have been depleted. Of course, in addition to that, the donors' fatigue, as we call it, poor living and sanitary and health conditions that do not contribute to positive health outcomes. In contrast, we have really high disease burden. And as Fouad was saying, there's a lot of focus on the infectious diseases. However, we have increasing data that shows us, evidence that shows us that the NCDs are also quite a burden that we need to address, whether it's obesity, diabetes, cardiovascular diseases, among others. Of course, poverty and then food insecurity, which is what I'm going to be focusing on more today. So as a definition, food security is when you have physical, social, and economic access to not just safe food, but nutritious, and that's also sufficient, and that not only meets the dietary needs, but also the preferences of people for a healthy life. This is a really big, if you want, definition that's based on so many pillars that we can talk about, but food insecurity, as you can imagine, is affected by wars, by migration, by population pressures, a lot of what we are going through in the MENA region with the Arab uprising, and definitely in Lebanon with the large Syrian crisis. According to the World Food Programme, Vizier report, which is the vulnerability of assessment for Syrian refugees in Lebanon, they've been looking at data since 2013, and as you can see that the picture is actually not good. You notice that the prevalence of food insecurity is increasing, with 32% being food secure early on in 2013. In 2016, only 7% of the refugees, Syrian refugees in Lebanon that are registered again, are food secure. This again excludes the heavily marginalized unregistered refugees, which is another kind of equation and story to talk about. We know from the evidence in the nutrition and the food security literature that there are so many challenges to ensure optimal fetal and child nutrition and development, as well as maternal development. And we think that there are so many nutrition-specific and sensitive interventions that could be tackling this issue. But mainly when we're talking about food security, the problem in Lebanon is that there wasn't really evidence to start with, and this is where I'm going to be zoning in my talk. So there are a lot of evidence out there about what do you do in humanitarian crisis. But in a situation in Lebanon when the evidence was actually mostly non-existent, researchers and community nutritionists like me were asking themselves the question, what can we do? And this is kind of going back to the conference whole theme, the role of the universities, the role of researchers. So some of the questions that I had and that many colleagues had early on in 2012 when we realized that this situation is not going anywhere and it's actually going to get worse. What are the main needs of refugees? That's some questions that we were looking at. What are the most effective and efficient interventions that we can actually mobilize? What's going on there? Are the mobilized interventions and programs being developed by different agencies in Lebanon, are they actually the most effective? What about the host community? And this is a story and a question that honestly took its time before it fleshed out. So if I were to actually summarize my vision at the time, it wasn't too nice and clear. I by no means claim that this is how it was. Probably down the line, I started thinking that this is where my contribution is. First thing that I started with as a community researcher, I started thinking, how can I integrate my students into this whole story? How can I involve students in this? Because I believed in community-based learning. I believe in students being involved because they're not just volunteers, they're actually the next workforce population. And we need to start thinking about this from that angle. So I actually started from number 3 in my work, and I'll show you some examples as we go. But then, of course, as a researcher, my mind started itching. Is anybody talking about the host community? I mean, there's a lot of work done on Syrian refugees, and this is very important, and the Vizier is answering that. But when I was actually thinking about it in 2014, there was really not much data about the host community. And that's where I started asking myself, what is the food security status of the Lebanese host community? What is going on in terms of our needs? What are some of the comparisons between the refugee and the host community? I know that we are better off, but is this in all areas? What about regions like Akkad, which is one of the poorest districts in Lebanon, the north of Lebanon? So these are some of the questions that I was grappling with as a researcher. And of course, as years flashed by, I started realizing that we can actually contribute by capacity building, by workshops, seminars, conferences like these, in order to talk to the policymakers, but also talk to the public health professionals like us who are really struggling with the same questions, and hoping, of course, to be advocates for policy level changes. So from a research dimension or angle, I started thinking about what kind of research questions I want to answer. So the first thing I thought about is, let me look in the greater Beirut area, an urban setting that doesn't really have much data on it in terms of food security. So I was interested, particularly not just the household prevalence of food insecurity, I was more interested in looking at women and mothers in particular. What's their status? There's so much literature out there about women being, at a disadvantage when it comes to the food insecurity status of the families, and that they are worse in terms of dietary intake and dietary diversity. They basically compromise their own diet for the sake of the children, and this is kind of really across many cultures, so I was interested in that. And then I went further and I actually conducted the first national study to explore household food insecurity in Lebanon, and I focused on mothers and children under 18. Study number 3, and by no means I'm going to go through the findings of these. I was just kind of telling you some of the questions that I was raising, and maybe I'll shed light on the results on the first 2 very quickly. The third research question came on board when I was thinking, okay, so everybody's talking about the refugees alone and about the host community as being at a disadvantage and that we need to work on them. So I picked one of the poorest districts in the country, which is Akkad in the north of Lebanon, and I looked at it from a very much a nutrition angle, also focusing on mothers and children. Study number 4 is more kind of taking a bit of a twist here, where I was done with assessment. I was like, okay, this is enough assessment. Let's do some business, some real work. As a community nutritionist, I was itching for an intervention. So this is an intervention that was done in collaboration with the Center for Civic Engagement here at AUB, with another organization, also Kayani Foundation, and Informal schools in the Bekaa, which is another region in Lebanon that you're going to see in the map in a bit, in case you haven't had the chance to go around the country. And we were looking at the impact of a pilot school-based nutrition intervention on the knowledge, the attitudes, and the behavior, dietary behavior of refugee children in the elementary level. And finally, that final study that's ongoing now is actually exploring the community kitchen as a modality for food aid that's different than the card that's being distributed by the WFP, the e-voucher card, and it's different than the UNHCR, if you want, package. So this is more of something that's very community-driven, women-driven by co-ops that usually cook food for beneficiaries who are Syrian refugees and very impoverished Lebanese host communities. We're looking at the perceptions and experiences of those, so this is the most qualitative, if I may say, and the rest were very quantitative. So the Beirut data was out earlier this year, and what was shocking to me at first, but then when you start looking at your data, you're like, this is not shocking in Lebanon. We had 50% that are being food secure, whereas the remaining population in the greater Beirut area was considered to be expressing some form of food insecurity. These are all, of course, experience-based, and this is something that we have to talk about. If you're interested, I can tell you a little bit about the validity of that tool and all that good stuff. So, but what's interesting is that 26% of the Lebanese population in the greater Beirut area were severely food insecure, according to their own perceptions. Of course, as I was interested in looking at the association between food insecurity and the nutritional status of the women, and what we found is something in sync with the literature, that women who come from food insecure households are at higher risk of being obese and also at risk of elevated waist circumference, two indicators of basically high risk of NCDs as well, so risk factors for NCDs. Even when we adjusted for all other factors, we looked at that association with obesity, and it held pretty strong. With the at-risk waist circumference, it lost its rigor, but that didn't deny the fact that it was actually there even when we went during the unadjusted version. Sorry, it's backward. This is shifting gears to the study, the national study, and this is basically a paper in the review that I'm very excited about, because what I really was looking forward to see is this national map that gives me this overall prevalence. And what I wasn't excited about, of course, is the prevalence that I thought was pretty high. So like in Greater Beirut, the prevalence of food insecurity was 53% among the Lebanese population, and this data was collected in 2015. So 2015 till 2017, things may have got better, it might have got worse. And that's one of the things that we're not doing, is continuous surveillance and monitoring of this issue, among others. What's the highest prevalence of food insecurity? It was in the north of Lebanon, reaching almost 60%. If we look at the Syrian refugee density and we look at it in parallel with the food insecurity prevalence, we notice that, so the Syrian refugee density is not data I collected, it's based on the UNHCR and the UN OCHA. And what you can see here is kind of a trend that as the Syrian refugee density increases across governorates, the food insecurity prevalence increases, except for the region of the Bekaa. That's a bit of a twist. And there are things to talk about in terms of the Bekaa. Why was the Bekaa protective for refugees? And it's mostly because of their agrarian communities and the fact that many of the refugees who reside there are actually also depending on those kind of jobs and employments that are allowed legally by Lebanese government, and that also is part of their skills and competencies even before coming, when they were in Syria. There are many of them were agrarian communities. Shifting gears here, this is where my research kind of interest doesn't end, but necessarily, I shift gears to what I do in my other kind of part of my days, which is the capacity building and community service dimension. So I was interested in thinking of how our students can benefit from this, from all what's going on around. I mean, many times the students were interested in traveling abroad to see what actually is literally in their neighborhood. So that was an eye-opener for many of them who started joining me in this journey, where we started looking at how can they learn while also benefiting the communities. So communities provide definitely a natural context of learning. They provide a meaningful and relevant context that students can start understanding, and it's in their neighborhood, as I said, so they didn't have to travel far to Africa or to Latin America like classically they used to think. It's actually happening near them. And at the same time, the community-based learning strategies definitely allow for those people that really need the majority of that intellectual and experience and competencies to be utilized in their communities. We gave the opportunity for the communities to benefit. These are some pictures from assessment activities that were conducted by our students. This is part of the nutrition program, the dietetic internships, where students were either doing this as part of their final year project or final year practicum. And I'm always proud of them because they came with so many different interesting, exciting projects and educational material, and they actually challenge themselves. And this is where you work in different informal tented settlements in different contexts. And finally, I can't but say that as part of this refugee health program growing, I want to say, family at the Global Health Institute, we have been thinking about the contribution of AUB and the contribution of us as different researchers from different departments. How can we contribute? And the goals of the refugee health program is definitely to be a hub for evidence-based, basically, practice and policies, but also we want to give back to the community. So what we have been doing, and this is our team, our lovely team, not everybody is around here, but they all would have loved to be joining us. One of the things that I know, Fouad, you can talk more about as well if we come up with questions, is this informal provision of health services for Syrian refugees in Lebanon. This is a project that started, and that's actually pretty interesting for us because it really ask the question, what's going on with all the great skills of refugees, Syrian refugees, doctors, nurses, midwives, who came from there and cannot actually pursue their job, but that are actually at much more need. We need them the most in their communities. And then the second grant is actually hopefully starting up soon, Research for Health and Conflict, and this is more towards NCDs. Different capacity building workshops we've been doing. We've been involved in either bringing people from the Bekaa or from the north of Lebanon to AUB or going there. We have been participating in the nutrition and emergency courses. And we also have been doing community outreach projects in the Bekaa. We hope to extend it to become much more frequent, where we involve our students. These are medical residents, these are dietitians, these are public health professionals, basically faculty of health sciences students. So we hope that this will actually allow for more of an integration of what we thought is an ivory tower. We are thinking that we're actually part of this community. We never stepped out of our comfort zone. This is our comfort zone. We love to work here. It's just a matter of making sure that this bridge is ongoing and it's a two-way street. And of course, thank you for your attendance today.
Thanks so much, Dr. Jomaa. So, Dr. Saleh, we had a very interesting overview of the needs and focus on NCDs. A very interesting summary of the outcomes of investigation on communicable diseases, and a very interesting question also posed by that. And then this food insecurity of refugees, and now the words to you, your opinion and expertise.
I don't have a no, that's perfect. So the 3-minute sign was already here. So
I took it away.
good morning, everyone. Thanks for the organizers, the conveners for inviting us. IFI, Dr. Nasser Yassin, my dear friend, and Yara and the colleagues. So my very brief intervention will have 3 components. The first is talking a little bit about the health system's response to the issue of migration. Secondly, talking a little bit about the potential role of universities in migration, which is the topic of this conference. And thirdly, telling you a little bit what we're doing at AUB to do an institutional response to all of this. So the starting section, or the beginning, is on the issue of health systems. I always try to think about any problem through sort of dissecting it to the smaller unit. In this case, it's the individual who is migrating. So if you think about it, the first 2 needs are the needs that have to do with shelter and with food. But shortly thereafter, the issue of health comes up. And the question that we have is, how well are the health systems, the receiving health systems, equipped to deal with that, with the migration? And what happens with the IDPs, with the internally displaced people, the people who are within the same country but are moving from one place to another? And the sort of the biggest refugee crisis in the world currently is the Syrian refugee crisis. And if we look at it as a scenario, we clearly find out that the receiving countries are Turkey, Lebanon, Jordan, and then the host healthcare system, which is Syria. So the question is, how did these 3 countries respond to the issue, to the health needs of the refugees? Interestingly enough, each one of them deserves to be a case study on its own. The key common thread in trying to think about the 3 healthcare systems can be summarized by the term of surge capacity, which means that how much each of these 3 healthcare systems are able to take on and provide services for more than they currently provide to. In the case of Turkey, the surge capacity was big because Turkey is a big country compared to the incoming refugee population. Yet, they were the most creative in addressing this from a health systems perspective. Not only were they organized from day one in how they provided the services, but they have evolved into establishing what they refer to as migrant health centers in which you have Syrian healthcare professionals providing services for their own refugees, which is an advanced model, and also provide some legal provisions for those healthcare professionals to work. Compared to a country such as Lebanon, which is my country, and our response has been haphazard, effective, yet haphazardly effective, which is a characteristic of Lebanon. So everything in Lebanon is haphazard, but eventually it works out in some way, shape, or form, as you're probably aware from reading the news, hopefully. So anyways, Lebanon wasn't systematic in how it approached it, so much so that if you have 1 in every 3 or 1 in every 4 people in the country being refugees, you would expect, and this is something that Fouad talks about quite a bit, you would expect that the country would allow at least Syrian healthcare professionals to serve Syrian refugees, which is not the case so far, okay? Which again, the haphazard approach in Lebanon. And then you look at Jordan, which is a medium case between the two. So this is when it comes to the sort of the host healthcare system. So what happens with the original healthcare system, which is the Syrian healthcare system? Before the conflict started in 2011, I would say a good percentage of indicators, of health indicators, were good for Syria, okay? The infrastructures within that Syrian healthcare system was, impressive given, everything and the economy and so on and so forth. So the question is, now that original healthcare system is divided into 3 healthcare systems. The first is the part where the regime controls, okay, or the Syrian government. The second part is the areas where the Kurds control. And the third is when, and this is declining, thank God, is the ISIS-controlled or the opposition and so on and so forth. And these are, different. So again, the question is, are these different healthcare systems responding the same or differently to the IDP situation? And also this is a part that is worth assessment. So in summary for that section is that you cannot assess the basic health needs of refugees without looking at the infrastructural healthcare system that is available there within both the host countries and the origin countries. So this is section number 1, and I have 2 minutes and 20 seconds for each section, right? They add up to 7 minutes. Okay. The second section is, and which is the title of this conference, is the role of universities in migration. So the thing about what happens in crisis is every single expert in the world or every single professional in the world becomes a refugee expert. So we have visitors that come abroad to Lebanon, and they say everybody we talk to in every single domain is an expert on refugees. So who should we talk to, right? So everybody, you have plumbers who are now experts on refugees in terms of the plumbing needs. So anyways, so the question is, what is the role of universities when all of this happens? And I think the universities have a critical role in, one, making sure that there is some form of a conceptual framework that guides this without being too much academic. So this is one. Number 2, of developing guidelines for interventions. And if we take the example of health, you cannot imagine the amount of mishaps that happened in the first, 3 or 4 years of the Syrian refugee crisis when it comes to medical interventions. And the third, I think, angle is the issue of monitoring and evaluation, so quality assessments and so on and so forth. And I'm sure that others will come up during our discussion. So the role of universities is critical when it comes to the problem of migrations, and we are a living example of all of that. So this is section number 2. My last section is to share with you a little bit what we are doing at AUB to respond to the health needs and to the issue of refugee health and so on and so forth. It was clear from the beginning that AUB, as many institutions in this part of the world, had a startup confusion. Okay, so what should we do? But shortly thereafter, we thought that the best way to do a systematic response is to institutionalize the response And this is what we did. And we did it on two levels. The first is in our vision on health that we are referring to as Health 2025. It's a presidential vision announced by the president of AUB. What we have said is that all of the health units within AUB, including our medical center, including our Faculty of Medicine, Faculty of Health Sciences, my home unit, nursing, nutrition, and others, all of these have to be aligned and they have to work together, okay? They have been working together, but not as much as we would like them to do, and we will strongly encourage them to do that, part of a new framework. But the other exciting development, institutional response, is the establishment of a global health institute, the first in the region, in the Middle East and North Africa, and specifically establishing a refugee health program that we have two of the three co-directors, part of our panel, Dr. Fouad and Dr. Lamis Jomaa. So by starting that refugee health program, what we are doing is we are both conceptually and analytically and practically engaging in the issue of refugee health. Not in terms of direct service, but in terms of at least doing some sort of a monitoring and evaluation system, developing the discussion around that. So in that, we are helping as much as possible to have the response be institutionalized, because for us, and I think you may share that reflection with me, is that tomorrow, if the crisis moves from Lebanon to Uganda, most of the people who are working in refugee health in Lebanon will move to Uganda. What will stay are the institutions. And hence this was our sort of strategy to build those institutions, so that even if the crisis happens in Uganda, we have enough conceptual framework, we have enough evidence to share that experience with other parts of the world. Thank you. I think I didn't use all of my time. Huh?
Thanks to everyone for very interesting intervention. And the first ask that I have talking about health is to please stop the air conditioning. Otherwise, I will get sick talking about the health of others. So if that is possible, I think you got distracted. The air conditioning, if it can be stopped, because it's thanks. Okay, thanks. Very interesting aspects. There is a big question posed by Kaveh on, I mean, if we come up with evidence, how does this affect actually the information and the spreading of the stigma or not, and which type of evidence we need to come up? Food insecurity, very, very interesting, the overview and how in some cases there are overlap between the hosting communities and the refugees. Very interesting, the overview and the focus on the NCDs in particular, at least to me, how that is important. And then also actually this role of being, I mean, an instrument to spread evidence and monitoring and evaluation, and then also guidelines for intervention of university and the importance of the health systems. For example, just to give you a contribution coming from another part of the phenomena, from a Western country, we do have the need in Western country to understand the health systems and the strength of the health system and the working of the health system in country of origin and in country on transition, to really understand how to better address the health of immigrants, both economic migrant and refugees in Western countries. It is a big need that we do have. And something that it is very, very important in our countries actually is also the psychological needs, the mental needs of migrants, and how to address that, to approach that, to also avoid other health diseases that they can develop once they arrive in Western countries. But I open to the question. We do have at least 15 minutes, isn't it? Yeah? Okay. Please. there is one there.
Hi, good morning. Thank you very much. I'm Assam Khouri. I work at the Arab Council for the Social Sciences. My question is to the whole panel. What challenges and opportunities do you face working in Lebanon, in a country that technically does not recognize the status of refugee because it is not a signatory to the UN Convention? So the question is, what challenges and opportunities does that present in your work?
Okay, thank you very much also for the informative lectures and presentations, I would say. It's not lectures. My name is Sahar Makhamri. I'm from Jordan. Actually, it's a question, but also it's an answer. A question for Dr. Fouad, but maybe an answer for Dr. Kaveh. Coming from background of social work and medical health care, I think one of my questions I always raise is always the history of medicine and the tension between other multidisciplinary team. To what extent you involve, for example, social work and social science with your curriculum in terms of communication and dealing with issues, raising awareness, community-based intervention, as our colleague Maisa mentioned. And this could be partly of an answer for you, Dr. Kaveh, right? Kaveh, sorry. Is that with social work, sometimes we deal with medical health, and when there is a stereotype, when there is issue that is sensitive to community, the best people to use advocacy is people who know how to advocate, and also people how to reach the outreach and how to tackle issue that's sensitive, like your study. One of the things that we've done with the London Medical School as well is that we disseminate the information as a play, simply. So it's a play for the community, and we tackle the issues that of sensitivity. And by doing this, actually, we managed to reach the outreach and deal with formal and informal leaders. This is something we could talk about it later, but this is just to flag out.
Eric, and then we take another one and we open for the second round afterwards.
Eric Bergler of the LSE. So one aspect you haven't focused very much on is the mobility of refugees and the challenges that poses to healthcare and so on. So first of all, if you can say something about how you think of that. Of course, mobility may have decreased somewhat now because of the changes in refugee policies in different countries, but you also have the issue of return possible and how you create continuity in healthcare. So one of the things we are trying to do through a study that we are doing together with AUB is actually to create 3 panels, one in Lebanon, one in Jordan, one in Turkey, and there is already a panel in Greece of Syrian refugees. The kind of questions we were thinking of, there are questions of around well-being and so on, but I see an opportunity perhaps to include questions that could be of interest to, and also perhaps what kind of work you are doing in this regard, trying to track people over time and across space in terms of health.
Thank you, Eric.
Hello. Thanks for this nice panel on refugees' health. My name is Dr. Diana Aoun. I'm an assistant public health officer in UNHCR Public Health Unit. 2 issues I would like to talk about. One issue about Dr. Fouad. At the end of his talk, he told that in Lebanon there are 3 parallel pathways for health. There is the Lebanese, the Palestinian, and the Syrian. Would like to clarify that UNHCR, as part of the health crisis, responding to health crisis and refugee, is using an integrative part of the Lebanese health system, it means that UNHCR is using the already existing hospitals and is using the already primary health care centers present in Lebanon. In fact, for hospitals, using hospitals through the TPA, the third-party administrator, and for, as a second issue, strengthening on what Dr. Aureli said about mental health, UNHCR is focusing a lot on mental health and psychosocial support for refugees in Lebanon, and thank you very much.
I think for now it's enough. Yes, you're right. So, and then we have another two afterwards. So, please, Fouad.
Yeah. So, thank you very much. Very interesting questions, and actually, I try to merge some of those questions together. So, for Isam, yes, I agree that. This is a major issue. I mean, what's the impact of having, like, not recognizing the refugee status? This is the component of legality, you know. If you're illegal, that means, you know, and when talking about illegality, it's about not just registration, you know, at UNHCR, which is important to get, you know, services, but also it's about, you know, a sort of residence permit, you know, to stay, and work permit. So if you know, and you know that after 2015, UNHCR stopped registering, you know, Syrian refugees in Lebanon, and then all people after 2015 are non-registered people or considered as a people in need, but are not registered. And even those registered have no rights as refugees, you know, in the definition of refugees. So these issues have actually huge impact on mobility and then on this accessibility to different services, including health. Of course, this is a major one, and that actually brings the issue that I used to, you know, to speak about, which is the issue of political determinants of health. This is not about economy. This is not about, you know, social issues. This is very political issue that needs to be addressed when thinking about status of refugees. And that's, I think, for Sahel, these same issues when having to address health that means we need to think about other issues. It's not health, it's political, it's economy, it's a social. You know, we're speaking on also, you know, issues of tensions that happen after the issue of, you know, burdening the system, you know, the issue of media that raise the different issues about the, you know, the burden of refugees on the system and blaming them of all these issues. We know that there's no evidence about, or sometimes the evidence are, you know, as UNHCR mentioned several times, they have like evidence that, you know, sometimes people bring more assets, you know, but of course media, you know, raise that. So having multidiscipline actually, let's say, strategies, you know, will be sometimes the answer of, you know, different issues. And last issue for the UNHCR. Of course, I'm very aware about the work of UNHCR with the Lebanese government, you know, using the same system. But sometimes this is the same question that I always raise. Okay, so you know that now accessibility to chronic disease is a major issue. It's not because, why? Because the system in Lebanon is a very privatized system. That means need to solve that, you know, the issue of how to deal with it, because UNHCR actually subsidizing 75% of hospitalization. The 25% of that, in many cases, when talking about chronic diseases, are huge, you know, in terms of that. So I think, and I know now, actually, UNHCR, you know, start rethinking about how to integrate that, how to think about the universal health coverage. There's a, an interesting discussion about that. So I think, yes, this is a sort of, it's working with the government, but at the same time, still having their a sort of different thinking that need actually to raise it. I mean, it's not just a problem of parallel systems, but also is how to coordinate different issues together to have a sort of and a quite good quality of services. I will stop here because I have many to tell.
Dr. Saleh, if you want to.
And I have only something that's very brief to add regarding the mobility of refugees. Just to say that this issue has implications on the healthcare delivery, because in many instances, throughout their route, the refugees are ending up in places with different health needs, but the system with different health needs, but it's obvious that their ability to sort of access their records or receive the appropriate care is questionable. So this is definitely an area that needs to be further explored, and we're working on this as a Global Health Institute along with the Refugee Health Program.
There was a couple of suggestions from me, so I appreciate that. I think there was a question about challenges and opportunities in working in Lebanon. For our HIV study, what I would say is, frankly, it was the most efficient study we had ever done. And I attribute that, we were able to do a study in less than a year from start to finish. And I will give the credit to very competent, strong civil society. The NGOs that we work with were just incredible. In terms of some of the challenges, I think Fouad alluded to that. We were interested in looking at hepatitis C in addition to HIV, but my understanding is that hepatitis C treatment is not available for displaced populations. It's very expensive, so we obviously hesitated to do any kind of a screening for a disease that we could not then refer them to treatment services. So lack of resources, medical treatment, limits the kind of research you can ethically do.
It's really good to be the last. I just add more stuff. I totally agree with my colleagues regarding, I saw also the same question of the gaps, the opportunities. This is a big question and it's pretty loaded. I think I always look at it, of course there's so many limitations that we can talk about and my colleagues already talked about, but I was thinking about it more of as an opportunity and not from an opportunistic angle, because that's really different. You can look at it from an opportunity in the sense that the lack of coordination between different sectors early on in this crisis have actually led to this whole momentum of let's think about how can we start prepare ourselves, because emergencies tend to happen in this region more than we want to admit. And it's not new, and it's not the first crisis, and it will not, unfortunately, be the last crisis. So kind of this thing brought many of the organizations, whether it's the UNHCR, the WFP, the international, and the local organizations, to start thinking more, hopefully, holistically, although there's still more work to be done. But I think we're doing a lot of lessons learned for our region, that's most important, and that many times we actually have challenged in a positive way the organizations that came from abroad with ready solutions that these don't work in this context. In a middle income setting like ours, Fouad talked about this, he insinuated to that in his talk, that whatever that package that you can work on in a low income country, it doesn't apply to certain settings. That cultural context specificity is what we're learning. So I thought of it as an opportunity. Another thing that, sometimes in the chaos or in the lack of certain organized, structures, many, as Kaveh was saying, many organizations step up. And the civil society in Lebanon has always been classically known for that work. And it's fortunately for us, because as researchers, you can always reach out. And this is the kind of work that we do. I think that the ministries are trying to basically follow suit, and the strategies differ because the ministry is different, because the political system in this country has been changing and unfortunately not always stable, as you can tell. So quote me on this one, right? So I think what happens is you end up working more in terms of whatever the system is and creating your own collateral systems that eventually can, hopefully the ministries can step up. And as I said, Ministry of Public Health has been doing that in terms of the health. In terms of food security, I would say this is where my area is. There hasn't been much work. It's a very much of an intersectorial thing that not one ministry can say, this is my ownership and I can own it and I can work on it. So the Ministry of Agriculture should be working with the Ministry of Public Health, with the Ministry of Education, but then there's so many other ministries that should be involved. And I think this is where we're grappling with. And with the lack of that, we don't have enough surveillance and monitoring to see if the status of the host community is getting worse or better. And that could be looked as an opportunity for researchers to tackle it, I guess. And there's, to be very frank, so much funding now being poured into this region for research, because I think there are so many lessons learned. So I would look at it from a positive angle.
Thanks so much. I think we have time for another couple of questions, and there is one here and then one there.
Well, thank you all very much for these very interesting presentations and contributions. I'm Gabrielle Wiedner. I'm the WHO representative to Lebanon. I have just been appointed a few weeks ago, while I have been involved since mid-2014 in the work here in Lebanon. So what I would like to say first, in this session, one thing that I really learned is that we need more dialogue between the WHO, UN in general, the implementers and the academia. Because while most of the information and of the perceptions that I heard from you largely concur with my own or WHO's, I would say, there are still some differences, and it's very important that we can discuss this and clarify it. Then I have a few comments regarding the infectious disease focus versus the neglect of non-communicable diseases, which I think in Lebanon is not that strong, that difference. First of all, of course, infectious diseases in every country, host country, they are concerned first about their own population, so infections coming in is the first thing to stop. But in Lebanon, I can see from our own experience that there is a lot of interest to support the non-communicable disease care for the refugees. And it's the easiest for WHO, for example, to mobilize resources for actual non-communicable disease care for many donors. However, other things like building systems for the resilience for the longer term is something where, of course, the government is interested and is working on it continuously, but the humanitarian donor community, they refrain largely from supporting this. Whatever we propose, it's very hard to get some funding for that. And I hope with the debate that is currently ongoing on this nexus and so that things might perhaps change. Regarding the role of academia, I think I agree with what you have been saying about guidelines development. However, this is an area also where I would like, if you do that, to do it together with WHO and of course Ministry of Health, because we do the same, we don't need it twice. And the research, I think there has been a lot of very interesting and important contributions by AUB and others in Lebanon. One experience that we are having is when we need some research question to be answered, it's usually quite acute. It needs a quick answer. So what we often experience from academic institutions is, of course, you want to go very rigorously into the problem. You have a very elaborate study, and it just takes too long. So what would be really useful is if you could also adapt to this kind of acute and crisis situation to have a bit more lighter, accept more lighter methodologies. Then one last thing, it is to you, Dr. Khoshnood. Actually, I'm very well aware of of this study, which has been done on the MSM, and I can give you some, I think, good news that not only based on that study, but also on other data and understanding of the situation in Lebanon, the Global Fund is providing funding for interventions targeting the key populations, those at highest risk in Lebanon, not differentiating between refugees and non-refugees, although the grant is supposed to be targeted only to refugees. But we told them, impossible. You cannot do that, stigma, and you cannot, and so on. So they agree. So that's something where your study contributed to, and I hope it's good news for you. The other thing is the new studies I hear about them for the first time. And again, we need more dialogue. I think this shouldn't be the case that while we host the National AIDS Control Program in Lebanon, WHO hosts it, we haven't heard about this study yet. So I would like to talk with you more about it, but I have talked already too much now. And excuse me if I have to rush out. There's a security management team. It's not just because I spoke now, I'm leaving. Misinterpret me, but thank you very much for listening.
Thanks a lot for this intervention. Please, go ahead.
All right. So my question is to Fouad, and the others are free to comment as well. So your last slide, you talked about the gap between relief and development, right? And I think you were talking about Paul Spiegel's paper as well. Now, humanitarian workers or relief efforts are usually a response to state failure or system or political failure. Do you think it is possible to build systems in the absence of political solutions? That means if the state continues to fail, how can you move from relief efforts to development if the state is not functioning? Because I see systems as essentially very political decisions that you make. System building is a political decision. So first, the question is, can that be done? And two, if that can be done, what would it look like?
That's okay. I think we can open it to our contributions.
Yeah. Thank you very much again for this very important comments and question. And I don't know where Gabriela is now. Anyway, so she raised very important issue. Actually, the last comment was really crucial one. This is a question to us, as an academia, how to respond efficiently but quickly to many cases. And we know that there's the academic system in doing research has been shaped around the issue of, slow motion thinking with all these ethical issues. I think this is another challenge raised to us. We need to do that, and we need to respond to that. And yes, I agree, we need to, to have this dialogue with the other entities. But I will leave the issue of question about the new project about this to Kaveh, because, I think that he has sort of information about this. Oni, I think, yes, this is a reality now. We have a reality that, many countries, especially I'm talking about the region, now, the extended region from, Turkey to Yemen. We're talking about instability and political instability since a long time, and political instability that leads sometimes to war, So your legitimate question, can we build a system, a stable system, let's say, in instability condition? This is the major challenge. First, we need to take in mind, in consideration, that this is, the political determinant is a substantial part when thinking about health, about education, about job opportunities. This is an issue that as health workers, as academia, we shouldn't ignore it and think only on the technical issue. Political issue is very important and need to be taken, and need to open this dialogue with others on that, and need to be engaged. I don't know if yesterday Iman in his speech mentioned that at the beginning we tried to say, no, this is not our job now, engaging in this political issue. We're offering research, we're offering, sort of a recommendation, but, engaging this, we are neutral. And I don't think that this is working anymore. You cannot say, maybe neutral in this sort of broader idea about that. We need to engage or to be, real researchers when thinking about that instability in politics is the condition now and need to have that. And then the challenge is how to build system which is maybe it's not a sort of system that can adapt quickly. I will give an example, and I know maybe UNHCR will be a bit not happy, but this is not UNHCR, this is UN agencies. Since, I came here moving from Syria, because I worked a lot on these chronic diseases and the issues there, I came here, almost 1 million people here, and there's this issue about, UNHCR, they have very good job that time, but there's the issue of, yes, you're okay, but after 6 months, people will come back to you asking about hypertension, diabetes, and cancer, all that issues. So how to respond to that? I think that time was a bit, they were not happy, which is, strangely, because the Syria crisis is not the only crisis that have this, long-term duration. The Iraqis before that, just on the, back doors, we have the same problem. So responding to that, having this in mind from early beginning, I think that could be useful. But what happened that this is not just a funding issue. This is about political issue. Because thinking about addressing chronic diseases, that means you need to engage more on integration systems together. That means, integration is very, problematic word, when talking about, that having, people, that means they will be citizens, which is, sort of a scary issue. So yes, I think you raised now the challenge that I think all of us here need to start thinking about that. This is a fact for the next 2-3 decades and need to be sure that we can do something during that time. Thank you.
Thank you, Fouad. Kaveh, you're next, and then we really need to close it because we are...
Sure. There was a couple of questions about sort of making research relevant to policy. There was questions about and this came up yesterday as well, research takes time. How do we make it sort of more rapid? I mean, one of the key steps, first of all, of course, you have to be asking the right question. You have to think about the right design. Doing a 5-year study design is probably not appropriate in this kind of a context. But also, one of the steps that tends to delay research is the whole human subject research review process, which is a very crucial step, but that could take many, many months, if not longer. And I know MSF has developed its own IRB, its own institutional review board, and there may be innovation that needs to be done in terms of making sure the ethical review of research protocols could be done more efficiently. The other thing I wanted to say is to make research more policy relevant or leading to the right policy, I think we need to think not just about doing the research, but how we do the research, and then what happens when the research is done. By how we do the research, I'm talking about making sure the people who are going to be affected by those results are included. I'm talking about the participants themselves, their families, their communities. And I think this is the kind of work that you've been doing, more of a participatory research approach, not forgetting the host community in this context, including the right stakeholders. And then what happens when the research is done? As researchers, frankly, the funders don't tend to expect us to do beyond publishing our results. But I think, as has been raised several times, we need to be doing much more that if we are doing refugee-related research in terms of making sure the results of our research gets out to the policymakers. So, thank you.
I'm sorry, we have to close it and we will go for the coffee, so Rawi.
Thank you, Francesco, and our guest speakers of session 4. We're gonna go for a quick coffee break, and then we will resume in 10 minutes, please. So let's try to be here in 10 minutes back.